Good evening,
Hello.
everyone.
Thanks everybody for coming. My name is Joe Marion. I'm the Neuro Service Line Chair. I want to welcome you to the first of several webinars covering cover the full spectrum of stroke care. Tonight we'll be hearing from a couple of neurologists as well as a resident from Einstein Medical Center. I'd like to first introduce Rakesh Ahuja. He's a PGY3 radiology resident at Einstein Medical Center. He's also the co-chair of the ICU service line, and he has a special interest in the annual meeting committee. I'll turn it over to Rakesh.
Thank you, Joe. I am currently a PGY3 resident at Einstein Medical Center in Philadelphia. As Joe mentioned, I do have special interests. One of them includes neurointerventions, and we'll see if that dream works out. I have two panelists here, Dr. Brady and Dr. Newman, who have very graciously extended their help to monitor this webinar. I'm going to do a quick introduction. Dr. Brady is our section chief of cardiovascular and interventional radiology. He graduated from Royal College of Surgeons in Ireland, and he completed his internship and radiology residency at Cleveland Clinic Foundation and fellowship, interventional radiology fellowship at Northwestern Memorial Hospital in Chicago. Dr. Brady has been expert in interventional radiology, pretty much everything under the realm of IR. He is one-stop shop for everything, and his primary interest is neurointerventions. At Einstein, he has done numerous procedures, which includes anywhere from diagnostic angio to complex neurointerventions, and he has been a top doc many years. The one great thing about him is he never says no. Always wants to give patients a chance, even if it's the most difficult case, which most people would just defer away. That's a small spiel about Dr. Brady. We have Dr. Newman, who is an extremely well-known personality. He is our chair for Department of Neurosensory Sciences at Einstein Medical Center, and he is double board certified in psychiatry and neurology. He has conducted tons and tons of research, some of which have been funded by NIH, and he also belongs to the core team who developed the reperfusion ADC maps, DWIs, back in late 90s for all of us radiologists. And I'm not trying to exaggerate, but Dr. Newman has treated more than 10,000 stroke cases. And he is an extremely, extremely useful resource. And I would like to thank you both of them for being here.
Glad to be here.
Glad to be here.
Thank you, and we will get to the presentation. So today's presentation is, since we just recently had Dawn and Diffuse 3 trials, which kind of were game-changing in management of stroke intervention. So we came up with the idea of doing a stroke intervention presentation of what it really means for us as interventional radiologists.
Hey, Rocky. Sorry, I was gonna just make a quick word here. Did you guys tell the listeners about like asking questions and things like that?
Okay, that's a great point. Thank you, Joe. So please feel free to ask questions in the chat. We will be monitoring and answering them right then and there. It's always better that way, and Dr. Newman and Dr. Brady prefer it that way also.
So yeah, so basically, well, usually we wait till the end of the webinar to discuss questions, and then this session, if you guys haven't discussed already, we're gonna be recording it, and then we'll put it up on YouTube afterwards, so that everyone from SIR-RFS can watch. Or actually, the public can watch. So yeah, go ahead.
Thank you, Justin. So we're gonna start this presentation now. So after this Dawn and Diffuse trial, we came to know about a lot of things, and there were too many relevant facts about everybody who's involved in stroke care. But the aspect of what it means for interventional radiologist or neurointerventional radiologist is something which was intriguing to me, as well as I'm sure many other residents. So Dr. Newman has helped me in putting this presentation together, and Dr. Brady has given me an immense amount of support for that. So we are going to go ahead and talk about that. I would especially like to thank, as I said, Dr. Brady and Dr. Newman. So going back to basics, this is where I started. Looking at this slide was the beginning of my career, where I looked at this amazing netter pictures of brain and the carotids and the base of the skull and different. I mean, this was too overwhelming to begin with, but as the career moved forward, I started understanding its in bits and pieces. So just wanted to put up there. So what is the new reality? So the new reality is basically Dawn trial said patients presenting within 6 to 24 hours who will do well after mechanical thrombectomy can be identified by delineating the core and using a clinical penumbra. Diffuse trial had similar uh, findings, except the time period was 6 to 16 hours who will do well after mechanical thrombectomy and can be identified by delineating the core and penumbra by advanced imaging, which includes MRI with perfusion weighted imaging or CT perfusion. So these trials are going to talk about a lot of things. So let's just get to the basics and understand what it all means. What is NIH Stroke Scale? So this is basically a scale which neurologist uses to assess the patients with level of consciousness, response, and give them some commands if they're following, the gaze, the visual fields, and certain score is assigned. And as you can see, there's a score listed next to the responses. With certain score, you can have a like a screening. It's like a screening method to understand what is the current state of the patient who is presenting with acute stroke. Just remember, higher the NIH Stroke Scale, worse the prognosis, and less than 4 is good prognosis. 4 to 20 is mild to moderate, and they're also these scales are also useful for determining whether you want to give TPA to these patients or not. Next up is what it really means for us. It defines the stroke severity. If the NIH Stroke Scale is 0, there is pretty much no stroke. 0 to 4 is a minor stroke, 5 to 15 moderate, and as you can see, as the numbers go up, the severity increases and the impact brain density goes on decreasing as the NIH Stroke Scale goes increasing. As for us radiologists,
Excuse me, can I interrupt?
absolutely.
Sorry, sorry everyone, George Newman. So I just want to, if you go back one slide, in the lower right corner where it says NIH Stroke Scale greater than 20, don't give TPA. In case anyone noticed that, I want to correct that. We do not use any score to prevent us from giving TPA, and you can have very good outcomes even with what appear to be very severe deficits if you get there fast enough. So sorry, I didn't want to interrupt, but I needed to correct that, okay?
No problem. Please feel free, Dr. Newman and Dr. Brady.
On the other end of that too, we would do people with a 4 if it was a complete dysarthria as well. So, you know, those are some old scales, the stuff in the red at the bottom there.
Okay, great. So this resource was found from the stroke.NIH's website, and I'm sure the bottom ones, as Dr. Newman said, please disregard, but it's still generally used as an assessment tool. With next, as we talked about this, and aspect score. It's very controversial, but it's a good starter point for all of us as radiologists. So what it basically means is you assign 10 points to different locations in the MCA distribution, and as you can see on the side, these are the names of locations. There is ganglionic level, and then there is a supraganglionic level. You assign a point, and if you see a hypodensity or a stroke present in any of these areas, you deduct 1 point each. So what's the clinical use of this? If the aspect score is less than or equal to 7, it predicts a worse functional outcome at 3 months, as well as symptomatic hemorrhage. And according to one of the studies performed, the patients with aspect score of less than 8 treated with thrombolysis did not have a good clinical outcome. But again, that's very controversial. That does not mean that this is the hard and fast thing that has to be followed. Modified Rankin scale. This is the functional assessment scale for the patients, where 0 means no symptoms at all and 6 is dead. Anywhere in between, it goes on with increasing the severity of the presentation. So there is no significant disability to begin with, slight disability, moderate disability, and moderately severe, where patient would need pretty much the complete assistance with everyday activities. It's a commonly used scale for measuring the degree of disability and dependence in the daily activities of people who have suffered a stroke or other causes of neurological disability. And it's one of the most widely used clinical outcome measures for stroke clinical trials. Now defining what does really a penumbra and the core word by itself means. The penumbra is basically a part of a brain which has acute ischemia, and that is at the risk of progressing to infarction, but it's still salvageable if reperfused in appropriate time. It is usually located around the infarct core, which is the tissue of the brain which is already infarcted or is going to infarct regardless of reperfusion. So the primary aim of this current acute stroke intervention is to prevent the penumbra from proceeding to infarct. And that's why these all trials were done, and how can we identify the penumbra as the cores, and how can we treat these patients. So this picture is, I guess, probably Dr. Newman's favorite slide. Uh, this is not just a cartoon, as he said. This is a real patient. If you look on your left on MRA, there is no visualization of left MCA. Now, corresponding to that, when you do a perfusion weighted imaging with the mean transit time, there's these different kinds of colors which flash in front of you. What does it really mean? These colors actually have certain set parameters by the softwares, where if you have a violet color, it's 2 seconds that the blood reached to that part of the tissue in 2 seconds. The light blue is 3, going all the way up to red is 8. So red is the highest and violet is 2 seconds. What it really means is that the blood is not reaching to these tissues in this amount of time. And so this is what defines the penumbra, which you can see in the perfusion weighted imaging. You really cannot see the core in the perfusion weighted imaging because it's not going to be there, right? By definition, core is the tissue of the brain which is dead and which is not having perfusion at all. So you're not going to be able to see in the perfusion weighted imaging. On the other hand, if you look at the DWI, which is a diffusion weighted imaging, that's where you can see the core. If you have a bright spot on DWI, that that is the core by definition. And this is how it goes: pipes to perfusion to parenchyma, and what perfusion really means is penumbra. Uh, Dr. Newman, do you want to add anything to it?
No, I mean, I think that's basically right. You can see on the in the left precentral gyrus that there's a very small infarct. So this is a guy with you picture the patient with you see an ICA-MCA occlusion. The patient, from our point of view, probably has an NIH Stroke Scale of 27. He's aphasic, he's hemiplegic, he's hemisensory, hemianopia, hemineglect. But when you look at the diffusion and perfusion scan, you can see that virtually the entire NIH Stroke Scale is recoverable in this guy, because the DWI shows he has almost no infarct, and his neurologic deficit is strictly a matter of hypoperfusion. And so that's just a huge penumbra. That guy's primed for a revascularization.
And as he perfectly said, this guy probably might be representing with major right-sided symptoms. But if you intervene on the right time, he might leave the hospital with just a small little wrist drop. And I think all of us would like to play with those odds. And going to the next slide. And there are certain ways you can also assess core and penumbras and hypoperfusion zones by these specific softwares. One of the example here is Rapid software, which is basically an automated MRI analysis software. So it assigns certain colors with certain areas where it can define. It's something like Hounsfield units, but not really, because it's an MRI. So depending on the density of the tissue in those zones, it assigns certain colors. So for example, this software has assigned a color of pink to the area which is completely not being perfused or is not really dense enough. So that by definition becomes ischemic core. And the other areas where it's hypoperfusion, it might assign different colors, as you can see in this given example. It uses a delay insensitive algorithm and is diagnosed if the relative cerebral blood flow is less than 30% of that in the normal tissue. So that's the cutoff that has to be there. So, and hypoperfusion is distinguished from minimally hypoperfused tissue if the time delay is more than 6 seconds. So that's something to keep in mind, that there are tools out there which can help us in assessing these patients with what's the size of the core and what's the size of the penumbra. And if there is a major mismatch, these patients are still eligible for reperfusions. Now, this is the core of this whole presentation. The DAWN and the Diffuse trial was a major study, and if you really look at those documents, it's a lot of pages to read because it has information about everybody, whoever is involved in stroke care, the neurologists, the neurointerventionists, the stroke teams, the residents, the fellows, everybody. But Dr. Newman came up with this slide where it literally in one slide, it gives you all the information about DAWN and Diffuse and compares them side by side, gives you the number of patients that they used. And the reason it says stop, because they reached their goal of preset criteria by even at this number of patients. So they literally stopped the study because of that reason. And if you look at the comparison, the real comparison was between mechanical thrombectomy versus standard care, and which includes TPA, blood pressure management, and all that stuff. And exclusion criteria for these patients were the pre-modified Rankin scale of more than 1 for DAWN and more than 1/3 the area of MCA territory seen on CT or MR. And for Diffuse 3, it was limited life expectancy, pregnancy, and unable to obtain imaging for any reasons. The inclusion criteria, pay attention on that because that's really important. More than 80 is the age for first group of DAWN patients, their NIH Stroke Scale of about 10, and the infarct volume of less than 21 ml. That was one group. The second group of less than 80, the NIH Stroke Scale of 10, more than 10, and the infarct volume of less than 31 ml. And the third group was the age less than 80, NIH Stroke Scale of about 20, and the infarct volume of 31 to 51. And for the Diffuse 3, the inclusion criteria was NIH scale for any patients above 6, the core, which is the dead tissue, of less than 70 ml on diffusion weighted imaging or CT perfusion, and more than 15 ml of penumbra. And the way you can calculate, again, as I said, you can use all of these softwares and they will do these calculations for you on the CT perfusion and perfusion weighted imaging. The penumbra to core ratio of more than or equal to 1.8. Now, just a small little pearl which Dr. Newman taught me just recently. You look at the less than 70 ml. And why did they come up with this number of 70 ml? It's really not, if you pay close attention, so the brain volume on an average is about 1.4 liters. Take out about 300 cc's for the posterior fossa. So the cerebral hemispheres are 1.1 liters. So that makes it 550 ml for each hemisphere. Of that, 40% territory is occupied by MCA, which is 220 ml each. And 1/3 of that MCA territory is 70 ml. That's where this number came from. This is just the other way of saying 1/3 the area of MCA. And the final the modified Rankin for these patients at 90 days was divided. So basically, it's 0, 1, 2 is good outcome, 3, 4, 5 is bad outcome, and that's basically the outcome scale for every stroke trial. So they did mechanical thrombectomy for 49% of the patients versus standard therapy for 13% of patients. And those who achieve relative independence is what they were trying to find out. And the absolute risk ratio for these patients was 36%, and the number needed to treat, if you look at it, it's just 2.8. That's really not that big of a number. You only need to treat 3 patients for 1 person to achieve complete independence. And the person, if think about not achieving complete independence, that is extremely expensive compared to doing these procedures and doing all what's needed for this patient as mechanical thrombectomy is concerned. On the other hand, for diffuse 3, it's again 45% for mechanical thrombectomy versus 17% for standard therapy. And for them, the number needed to treat was 3.6, which again, even this is pretty good. Just giving you other example, there are certain drugs in the market where they have number needed to treat is like thousands for one person to get effect. And these are one of the most commonly used medications as well. Of course, I'm not going to name any of them because of the copyright issues. But again, just remember, number needed to treat of 3 and 4 is really, really low. And the
Yeah, that's a
mortality.
really, sorry, that's a really important point. Is if you look at heart cath and in doing coronary interventions, it's up near, I'm not sure exact, but I think it's around 20. So this is huge, huge numbers, really strong data. Sorry,
Sure,
Rob.
just to stay with that, to operate, do an endorectomy on a asymptomatic carotid, the number needed to treat is 127.
Yeah,
Wow.
so this is as strong evidence as just about anything in medicine. Certainly any interventions in medicine, this is as good as it gets. It really is very strong evidence.
I agree with that.
Perfect. So the mortality for the patients who underwent mechanical thrombectomy versus standard therapy, if you look at the numbers, it's not really that different. I mean, 19% versus 18% for Don and 14 versus 26. I mean, think about that, giving these patients a chance of mechanical thrombectomy and probably opening up their vessels with leaving the hospital with minimal uh, the neuro deficits versus major deficits, even if they survive and being in the vegetative state. I think everybody here will agree that giving a chance to a patient is much more useful. And the intracranial hemorrhage rate was also not much different, and the numbers that they were able to achieve was not significant. And also the part is because their total number of patients, the power of the study was not that big, and if they had like thousands of patients, probably this number would be useful. But at this point, it's not. Dr. Newman and Dr. Brady, would you like to add something to this slide?
I'm good where you are right now.
No, I think it was a really good synopsis.
Yep.
Okay, wonderful. So knowing all this information, let's come to a point. Now, what do we do? Now that we know so much more about the current intervention, the current care, what we are supposed to provide. So what do we do now? Let's go with this. How do we react to this with available resources? Should we do a stroke protocol CT for everyone out to 24 hours, which is about 75% of all stroke patients? What imaging do you want to perform? The advanced imaging, which even includes MRI, A perfusion or CTA perfusions on everyone, or in whom do we intervene? So let's answer these questions. Without a doubt, this slide defines everything, right? So the number of stroke calls per night has increased exponentially over the last 10 years. And as the windows expanded from 3 to 4.5 to 6 to 7 to almost about 24 hours now that we are seeing these level one evidence. So there is no effect of time on the outcome of these patients who are selected as having a significant penumbra with a small core, or are treated with mechanical thrombectomy all the way out to 24 hours, is what we have established from these trials, right? So let's see. When these patients are treated late in the game, when they present, as the time passes, the mismatch gradually decreases with time. And what mismatch are we talking about? We are talking about core to penumbra. About the first 25%, about more than 25% patients who present in first 6 hours, they have a core to penumbra mismatch of 10 times. The penumbra is almost 10 times the size of the core. Another 25% at after 6 hours, they present with penumbra size of 3 times the size of core. So that makes it about 50%, and this number decreases very, very slowly. So up to 15% is the mismatch by 24 hours. And next is the IVTPA. The window has not changed. 0 to 3 is definite. 3 to 4.5 hours is possible, excluding contraindications. And this was proved by a large meta-analysis which shows improved results with mechanical thrombectomy in patients who receive IV TPA prior to mechanical thrombectomy. So better outcomes and more first-pass successes. So giving TPA within these time limitations is really important if you're going to intervene, because intervention will become much more easier also. And again, as Dr. Brady likes to say, remember, time is brain. Brain, every neuron is very, very important. Uh, it literally is in seconds. And I have heard his lecture so many times, and every time he makes sure we know this emphasis. Time is brain. Remember that. And pretty much this is all driven by new IR catheters, the advancement in technology, everything applies to patients. This all data and all this stuff applies to patients with leptomeningeal artery thrombi, which we call them as large vessel occlusions, or in short, LVOs. We are going to use this term LVO, so that's what it means, large vessel occlusions. We are not going to talk about lacunes or distal MCA or unknown for PCA, which has very small penumbra, and basilar, which could be continued up to 24 hours and beyond. You can still intervene on that patient, and not for stroke mimics. Again, here we are going to talk about the major large vessel occlusions. Okay, and this is just a picture showing what's the penumbra device, which is a suction device, and next are some example of a stent retriever. We have a few which are FDA approved. Again, this also, you just push it inside the thrombus where you know it's occluded, open up the stent, it's gonna literally just bring it out. It's crush it against the walls and bring it out. Now, what are the imaging proposals for these patients who present as acute stroke? Are we going to get MRI with angio with perfusion on everybody, or non-con head CT or CTA, CTP? You can read through it. I mean, there are so many variables and permutations and combinations of head CT, CTAs, MRIs, perfusion. Or the big question is, when a neurologist examines the patient, they present in the ER, they tell you it's a large vessel occlusion. Do you do nothing? Go directly to angiography table and get a medium resolution head CT on table to rule out ischemic, to rule out hemorrhage. And if there is none, proceed ahead with the intervention. That's also an option. But let's think about that. So what drives this diversity of opinion and so many protocols? The answer is collaterals. It's an old saying. Collaterals determine the outcome of all strokes. If the patient has good collaterals, we have time to do our job. If they don't, we don't. I am going to emphasize on these collaterals more. I'm going to show you some examples, and there will be questions which you feel free to answer in the chat section. It might be something useful for you guys to know. So these are few examples. At this current scenario, at this current day and age, we don't do multi-phase MRAs and CTAs for these patients, but let's say hypothetically, if we did, the first images on the left show you the site of occlusion with 3 different patients who one of them has good collaterals, one of them has intermediate collaterals, and one of them has poor collaterals. So look at the site of occlusion at the time of their presentation. Patient 1 with good collaterals has left M1 occlusion, and 2 who has intermediate collaterals also has the same occlusion at the same spot, and the guy who has poor collaterals has right M1 occlusion. Now look at the differences in distribution over certain phases, and phase I mean delayed imaging. On phase 1, phase 2, phase 3, it's pretty self-explanatory. As you go further in time, you are going to lose the opacification of vessels depending on how good the collaterals you have. And just if you look on the comparison between the good collaterals on phase 1 to phase 3 versus poor collaterals on phase 1 to phase 3, as Dr. Brady likes to call them, desert sign. You literally have nothing. So the patients who are going to have poor collaterals are the ones who are going to present very hyperacute and probably not going to do well if they present late in the stage. So let's look at some more examples. Now, the MCA patient with poor collaterals is going to present hyperacutely, as I said. Rapid evolution of infarct, and here the time is extremely critical. think in terms of minutes. CT usually reveals very early infarction or swelling, and the dense MCA helps identify the problems but doesn't correlate well with the outcome. The patient with good collaterals, they do present acutely but are relatively stable with fluctuating deficit and may see clinical improvement. Has persistent penumbra if you do the advanced imaging with stable and slowly growing core. Here also time is important. Regardless of what the patients present with, time is important in every case. But here, the time, maybe we are talking in hours, not minutes. The cell death is occurring, so again, don't delay. And these patients, the CT shows less than expected given duration and the size of the deficit. So CT probably will not show you much of an infarct at that time, but is all because they have good collaterals. Next is how do we recognize these large vessel occlusions? Dr. Noguero was the principal investigator of Dawn. His opening statement was the best LVO detector is a good stroke neurologist. At Einstein, we are extremely lucky in a sense that we have an amazing stroke team, which is led by Dr. Newman. And if it's really hard for even a second year resident or maybe the first year neurology resident for them to miss LVO by August or maybe let's say September by the time they come in. It's really hard for them to miss. I mean, they would find it before you find it. And the leptomeningeal vessel strokes, which conform to the MCA distribution sensory motor patterns and are associated with deficits of higher cortical function. Generally, the NIH Stroke Scale is higher than the lacunes, which is typically more than 4, but may not be. Lacunes are easy to recognize. The CTA and MRAs will both show the large vessel occlusions and the collateral pattern. So now knowing all this, is that additional information by performing advanced imaging worth it? Now CTA depends. CTA adds about 24 minutes to the whole process, and MRI with A angio adds about 73 minutes on an average. In patients who present with poor collaterals, what do you think is going to happen with so much time spent? As we said, time is brain, right? So this is a disaster for them. And in patients with stable collaterals, there will be little indication of infarction even while after significant symptom onset. But again, look at this end quote. There was a study done at UPMC. The extra time is being used to identify 17% of people who will not benefit and experience a 16% complication rate. So let's multiply that, which is the 2.7% risk for intracranial hemorrhage. But this delay now punishes about 100% of patients, which the other remaining number of patients who are going to benefit from mechanical thrombectomy straight before doing these advanced imaging. So, but there is again no advanced imaging criteria to reject a patient. So now,
Yes, if I could just interject for a second. So
sure,
everyone listening is saying it doesn't take 24 minutes to do a CTA at my hospital. We do it on the table. It doesn't take that long. To which I say, this is the data from the trial. And also, I strongly encourage you to go up into the CTA control room during a stroke alert and watch the CT tech. And you will see how long it takes to perform, upload the images and get the system analyzed. And you will see that it adds about 20 minutes on average. I know that you think that's excessive, but having watched many of these myself, I'm telling you, that's what it takes. That's how long it takes.
perfect.
So I just have to make a comment here too. I know George and I, we debate this very hotly. I don't want anybody to take away from this that you shouldn't be doing a CTA. That is the standard of care, and I think you can definitely bring it down much less than 24 minutes. But the CTA adds an immense amount of information in all the trials. In fact, the difference between 2013 and 2017, where in 2013 all the trials failed, in 2015 when all the trials were positive with Mr. Clean and Revask, was that they were all using CTA to use their inclusion criteria. So CTA though it does add a little bit of time. And George and I, we debate this all the time, so I just have to give my side of it. Is a critical part, in my opinion, of triaging patients.
But Paul, I think you'll admit that under certain circumstances, we've simply brought the patient down to you directly.
Under rare, there's a dense MCA. It's a young person who, young people don't tolerate ischemia as well as older people, and you know, it's an attending senior stroke neurologist is making the diagnosis. Yes, but in the vast majority, in our protocol is a CT CTA at the same time.
And I would like to add one more important thing. Yes, it does add time. Again, it also is debatable who gets it or who doesn't. But as Dr. Brady also mentioned, CTA does give you a lay of the land, especially the arch anatomy, because if the arch anatomy is really that bad, you really will be wasting too much time trying to get through the variants of aortic arch. Uh, I mean, given that if you look at the CTA right before doing the intervention, you'll get the lay of the land also, if you get the CTA. So let's look at this example. So we talked so much about all these terminologies and acute LVO symptoms. Now this patient presented with acute LVO symptoms. A senior neurologist has seen this patient and they say it's LVO, and the initial CT non-contrast was done. And what do you think the aspect score for this patient is at the ganglionic and supraganglionic level? At this point, we don't see any hypodensities, right? So at this point, if you have to assign an aspect score, you probably will assign 10, right? Let's look at, but because there was a little bit of discrepancy, now patient went ahead and did receive an advanced imaging, which was a perfusion imaging, a CT perfusion. Now, if you look at that, the perfusion is showing almost all of the MCA territory involved on the right side. And again, remember, there is no hypodensity seen on the non-contrast imaging, so there is very minimal core. But since by definition, this is more than 1/3 of the territory of MCA, now this patient wasn't intervened because the chances of that this patient will convert into hemorrhagic transformation are high, and the outcome will not that be great. But guess what happened next day? This is disaster, right? And I would like Dr. Newman to input here because I know when we talked about this, he had important stuff to say about this. Dr. Newman?
Right. So yeah, as people who use a lot of diagnostic criteria, I think that it's important for you to know that the approval of any diagnostic criteria, any test at all, is a very complex thing. At first you develop it technically, then you apply it in lots and lots of patients so that you can figure out what it's showing. But then that's the easy part. What comes after that is the demonstration that the technique allows you to make a clinical decision on when to intervene or not intervene on a patient. And all that I would say right now is that we do not have any criteria by advanced imaging that allow, or frankly, or any other criteria, clinical or otherwise, which allows us to say that this patient is too severe to go on to mechanical thrombectomy. So we don't do that, and as Paul said, our numbers are a lot better because we follow the criteria which were set out in the trials. But those were just trial criteria, and I would say that we don't yet know that the picture that you're looking at there indicates that the person shouldn't have had the procedure. And that next day result was entirely predictable if you don't intervene. So then that's all that I have to say is we don't know the limit of when to stop yet.
And as I mentioned in the beginning, these are those patients Dr. Brady will definitely give them a chance. Please correct me, Dr. Brady, if I'm wrong, but I'm sure you would have given him a chance of doing a mechanical thrombectomy at this point, right?
Yeah. I mean, you have to take every case individually. You have to involve the family and the patient, very heavily in the risks and the benefits. But yeah, I would certainly, I tend to go towards more offering intervention. I think one of the things the studies have really shown is that especially mechanical intervention doesn't really increase your bleed rate as much as we originally thought it might. So I'm pretty aggressive at offering people intervention, yes.
Right, if I could come back on that. So I agree with everything Dr. Brady just said. I will also point out, again, knowing that I'm talking right now to a diagnostic radiologist, if you look at the original head CT, one of the things that I hope should jump out at you is that this person has no atrophy. So if an MCA stroke develops, he has absolutely, or she has absolutely no tolerance for the swelling which is going to occur. And so the set C that next day was entirely predictable, just entirely predictable. And you call the neurosurgeon basically when you're taking care of the person in the ER and let them know that sometime tomorrow they're going to have to be doing a hemicraniectomy. So that's a big deal. So there's a lot of information on this slide.
And I would like to certainly rub at this point again, as Dr. Brady mentioned, every case has to be considered on an individual basis. Everything needs to be talked about, the family conversation, the patient, if it's patient's probably not going to be able to listen, but everything has to be considered on an individual basis. Moving forward, so with all that information, shall they all go to a comprehensive stroke center? Now, there is plenty of political pressure to do so because everybody wants to send the stroke patients to comprehensive stroke center. But even if with the conservative estimates for a small city university hospital, it's additional 770 stroke unit admissions per year. It's not realistic with existing resources. So now what to do? So let's look at the scenarios. This is a 54-year-old male, right-hand dominant African-American male who presents with typical left MCA syndrome, NIH Stroke Scale of 26, and is brought to the ER within 2 hours after witnessed onset. Now this is very early, right? Let's answer some of the questions. The non-con head CT shows developing infarct in the left temporoparietal junction and possibly in the left frontal lobe. Basal ganglia are still delineated. What I'm trying to say is it's still less than 1/3 of the MCA territory. What additional imaging is needed? Do you do a CTA in these patients? Now, we would say it's debatable. We can argue to bring him down to the IR suite right away, or it depends. We'll talk about why would we do a CTA. What do you expect his collaterals to be? This is 2 hours after the witnessed onset. So what do you think his collaterals will be? I mean, in 2 hours he's crashing, right? So it's pretty bad, right? Should you give IV TPA to these patients? Remember, it's 2 hours. So I would say yes, and you would give them now. Would you call the IR team to come in and intervene? Absolutely. These are the patients you definitely need to intervene. When? Now. Well, if you're going to intervene, the answer is always going to be now. Where should these patients be managed? Pretty much if you have a choice, then it's always going to be a critical stroke care unit. Now, let's look at this. Yeah.
Rakesh, I'm sorry. Yeah, let's just stay with that for 1 second. On the issue of collaterals, so right, you know that since his CT scan is already showing infarct, his collaterals are not very good, and so you're moving as fast as you could possibly move. And that is why you might bring him down without a CTA. But I know I'll save Dr. Brady the trouble. Dr. Brady would say the protocol is to get the CTA and have it when you come down. The other issue, though, that I wanted to point out on this slide is the question of should you give IV TPA? I mean, this is it. So if you're doing this well with mechanical thrombectomy, is it worth running the risk, taking the time, the expense for IV TPA? So first of all, we start our IV TPA while the CTA is being done. So there isn't really additional time in this. And then from the other point of view is that there's plenty of data. People have asked that question. The literature answers that question. You have far more successful first pass attempts when you give IV TPA, and it is demonstrated that the patients do better. So the answer is yes. And again, there are two good studies that demonstrate that you do want to give IV TPA when you're inside the 3-hour window as you're on your way to mechanical thrombectomy.
And also adding one more thing, that giving IV TPA has also shown that there is a good first pass success on these patients. Now, looking at the second scenario, again, the same patient, now he has same symptoms. Now he presents at 7 a.m. after going to bed at 11:30 p.m. the night before. So by definition, this is a wake-up stroke. So again, the non-con head CT shows the similar findings as before. What do you think the additional imaging you would get in these patients? I would say probably a CTA again, right? Just a CTA should be enough to see if there is an occlusion, how are the collaterals, what's the arch anatomy, what his collaterals are you expecting to be? I would say that since this is a wake-up stroke, we really don't know. It could be anywhere from pretty good to pretty bad. Now that depends. If he had a stroke, let's say at midnight, and he woke up at 7 a.m., so which does say that he sustained this far out, so his collaterals are really good. But maybe he had a stroke at 6:30 a.m. and woke up at 7 a.m. in distress, so his collaterals are pretty bad. So we don't really know. And should you give IV TPA to these patients? Again, the last well known for this patient was 11:30 p.m. and he's showing up at 7 a.m. So that's beyond the window. So you cannot give IV TPA to these patients. Should you call IR? Yes, immediately, because this is again a wake-up stroke. You don't really know what's going to happen, and you would like to give the chance to this patient with mechanical thrombectomy. And again, where this patient should be managed is the same answer: acute critical care unit for specifically designed for stroke if given a choice. Uh, Dr. Brady and Dr. Newman, would you like to add something to the scenario?
No, I'm good.
Yeah, that's a tough one, you know, because you don't know. His symptoms could be 2 hours old, or they could be, you know, as you say, 8 hours old. But I think everything you said is right.
Well, I think I will add this. Would you would you send the patient for an MRI on the way to the interventional suite? That's going to add an hour or more.
So I think that's a question that we really don't know yet, and the one that we desperately need to answer is where MR and really advanced imaging fits in this scenario. And you know, the literature would say yes, we should get perfusion imaging because that's what they did in all the studies. In practice, as you in some of your slides mentioned, that the UPMC group, and I know George feels this way as well, is that with really good clinical examination and in rapid like CT and CTA imaging, we may be able to skip the advanced imaging, and which really does add an hour onto the timing. But the literature would say you need perfusion imaging. Will that pan out 5 years from now? We just don't know.
And again, to stay with it because it's worthwhile, I rely very heavily on the non-contrast head CT. Notwithstanding of that slide, that ABC slide that showed that the aspect score really doesn't perform very well, I rely a lot on the fact that the head CT does not show any major infarct yet. You can see the infarct developing, but it's not established. It certainly is less than a third of the MCA. Me, I'm on my way. I'm like I'm more aggressive than Dr. Brady is, and he's aggressive.
And we are lucky to have you guys.
Well,
let's look at the third scenario. Again, the same patient now just presents he presents after being found down at home almost a full day after last well seen. So there is almost a full day has passed. Now you see the same non-con head CT results. Now question is, would you do any additional imaging? I would say yes, to get the CTA, just to get the CTA and get an idea of what is blocked. What do you expect his collaterals to be? Again, the answer is it's variable. He's been found down and he's brought in after a full day of last well seen. So his collaterals, I mean, he's found down, he's not responsive. So either his collaterals are good, but the answer to this question is, and I remember when Dr. Newman presented this slide, someone from the audience said, it's not good enough. Well, that's the answer. His collaterals are not good enough to keep him okay. Would you give IV TPA to these patients? Absolutely not. I mean, it's beyond the window. Would you call IR in these patients? Probably not, because it's almost been a full day. He's outside the window doing any intervention on these patients. Again, it's a very risky thought. And these patients have to be managed with standard therapy pretty much. And also, I'd like to add one more point. Doing additional imaging in these patients who are way beyond the window, personally think that it's probably not going to add anything to and change anything to the management. Even if you, let's say, find out he has a big penumbra, or he has, I mean, I'm pretty sure at that point his score is going to be big. But doing an intervention with the full day has passed, I don't think it's much more useful at this point. What would you say, Dr. Newman and Dr. Brady?
Yep, I'd point again to the non-contrast head CT as what's making up my mind here. Once I have that, the truth is I don't need any additional imaging. You can look at the CTA if you want, but if the patient had a history of any renal disease or if he was diabetic, I wouldn't run that risk. He's not getting TPA. Once you're over a third of the MCA visible on the non-contrast head CT, it's simply time to stop. They're not going to do well at that point.
Yeah, I mean, the 24 hours doesn't bother me that much, but the entire left MCA distribution on a non-contrast CT, if he was 2 hours in, I wouldn't take him. That's the key. If you're seeing it on a non-contrast CT, they're too far gone.
And I would agree with that. And so on our earlier experience with the more advanced imaging with perfusion and diffusing, every once in a while we saw a patient come in as short as 75 minutes from stroke onset, and the diffusion image and the perfusion image were absolutely identical to one another. They were identical. The patient had 0 collaterals, and that was that. Within 75 minutes of stroke onset, and there's no further therapy that's going to help.
Yeah, the collaterals are the key. The analogy I use, if you stick somebody underwater for 6 minutes and completely deprive their whole brain of oxygen, they're brain dead. And so if half the hemisphere is completely deprived of oxygen 100%, it's going to die almost immediately. And everybody has some degree of collaterals. Even these desert sign people, that slide Rocky showed way out had a little bit. But if there's no collaterals, the brain is going to die very quickly.
So to just we could stay with that for a second. I think that's let's go over the time. The half-life of TPA in the brain is 3 seconds. 3 seconds, okay? 15 to 30 seconds into complete cessation, you have no more ATP left. Within a minute, you have electrocerebral silence, and within 4 minutes, you have neuronal death. That's the time frame that we're dealing with.
Wow. So that answers all these questions. You see entire left MCA distribution. Again, doing additional imaging and advanced imaging is probably not useful, as Dr. Brady and Dr. Newman suggested. So these are the 3 scenarios with 3 different patients. Now, in summary, when the patient has hyperacute, the patients who present hyperacutely are, these can be, the LVOs should be identified clinically by the presence of a typical MCA pattern, which may confuse with large PCA, but that's okay, because nothing changes in the management. IR has to be notified of the potential case as soon as non-con head CT shows no intracranial hemorrhage. The stroke intervention team has to be immediately activated upon IR's decision. If the patient is presenting hyperacutely and IR is immediately available, initiate IV TPA infusion and move directly to IR without CTA. If IR will take more than 20 minutes to prepare, proceed with CTA. And these are the suggestions. With patients who have wake-up or a questionable presentation, and the non-con head CT shows less than 1/3 the MCA distribution, the patient has neurological deficit that extends well beyond the infarct on the CT, notify interventional radiology, obtain CTA or MRA or MRI depending on time until IR and MRI is ready, and then proceed to IR. The other alternative is that if the non-con head CT shows 1/3 MCA distribution, just stop at that point and treat conservatively regardless of the time last well known, because it's, again, every patient has to be identified on an individual basis, but generally these patients don't do well even if you intervene. And if you cannot get a good history and physical on these in these patients, you need advanced imaging support, which is MRI, angio, perfusion, or CT angio and perfusion.
Right, so it's just worth commenting that the DAWN trial in particular used this clinical penumbra. So they defined the core by either diffusion imaging or CT perfusion. Both seem to work perfectly well. But then they might or might not have perfusion imaging to determine the penumbra, like Rakesh showed you earlier in this talk. And instead, they used the neurologic exam. So if the patient had a Wernicke's aphasia, then the temporoparietal junction was affected. If it was Broca's aphasia, Broca's was affected. Up onto the leg, then you're getting all the way up into the anterior cerebral distribution. So they used the clinical determinant of the size of the stroke. And if the clinical stroke, as judged by the neurologist, was larger than what was seen on CT scan or CT perfusion, or best of all, diffusion-weighted imaging, then they said, then there's a penumbra, and we're going to go get it interventionally. That's the way the trial was designed.
Wonderful. So the last slide is the take-home messages. The HNP, including the last time well known, when combined with non-con head CT, should be sufficient to make decisions in about 90% of the patients. Advanced imaging, which also including CTA, is a luxury to be used only when time is available, or for example, if activating the IR team requires time. And the advanced imaging is important when it is not possible to obtain the accurate HNP. With that, I'd like to conclude. Please feel free to post any questions. And Dr. Brady and Dr. Newman, if you would like to input some ending notes.
I think the only thing I'd say is that that last slide with those recommendations, that's my way of thinking. The viewpoint is definitely of an experienced stroke neurologist, and I think that that's about as aggressive as it's possible to get with minimizing the advanced imaging on your way to IR. And I think, in all fairness, I would say that most people would say that's more aggressive than they want to practice and would like more imaging on their way.
All right, thank you, Rakesh and Dr. Newman and Dr. Brady for that presentation on Diffuse 3, DAWN, and all the finer points of patient selection. We probably have time for one question if anybody has anything they want to type in to the question box. While we have a minute here, I want to give a quick plug for our next webinar coming up on the 16th next week. We'll be discussing some of the finer details of the advanced imaging techniques for acute stroke. And I guess I have one question for Dr. Newman and Dr. Brady. Given how strong the evidence is in these two trials that Rakesh discussed tonight, what do you see? How do you see it playing out in bringing this treatment to the masses? You know, making it something that is available to a large number of people.
Well, we're doing that already. We're already offering people the advanced timing. It's just we just have to refine, our protocols and how we do it. Specifically, as we've talked a number of times already tonight, where kind of where and when advanced imaging fits in. But I think the evidence is clear. There's two randomized, multi-center, controlled studies that just have really strong evidence that we should be extending our time frame. And I think most practices, that's what they're in the process of working out their protocols to do.
Right. I would add, I guess, 2 points. The first point is that every time I take care of a stroke patient, no matter it goes well or it goes badly, I always walk away saying, next time I'm going to be more aggressive. I always want to be more aggressive. I have not ever found the limit for how aggressive we should be, because you pay the price later on if you don't deal with it up front. My second point would be that 3 years ago, taking stroke call at Einstein at least meant that I'm going to get 0 to 1 calls to give IV TPA within a 3-hour window, and now it would be a rare night that I don't get 4 or 5 calls. So, so life for the stroke neurologist has changed with opening the window.
All right, great. All right, briefly, we did have one question come in, and then we'll be done. The question is, what is your take on the use of tenecteplase and its future?
Tenecteplase corrects a lot of the problems with the IV TPA, because basically it's a change in the enzyme so that it has a longer half-life. It can be given as a bolus instead of an infusion, and the data looks, the recent New England Journal paper suggested that the tenecteplase is going to be at least as good, probably better than IV TPA, and I think it will replace IV TPA very quickly.
Yeah, I think tenecteplase has been around a long time too. Personally, I think I've used both of them, but I use TPA everywhere in the body, and I think they both work really well. And I think there's some marketing differences between them. You know, maybe tenecteplase will be better, but I think they're both pretty much equal drugs, at least in my experience.
Yeah, unfortunately, there's a drug called desmoteplase, which is probably better than either of them, which has been hung up in trials for a very, very long time, and it has a lot of advantages, and it's never made it through the FDA cycle. Neither did pro-urokinase, though, did it?
All right, I think that wraps it up for tonight. Again, thank you, Rakesh, Dr. Newman, and Dr. Brady for taking the time to give this presentation. And I hope to see everyone back next week for our discussion on imaging and acute stroke.
Great. Thanks for having us.
Thank you, Joe. Thank you, Dr. Brady. Thank you, Dr. Newman.
My pleasure. Thank you. This was great.
Thank you so much. Appreciate it.